Oh, there's no one watching?
But I'll get there. Nope, not yet, but we are live.
Oh.
Hello, everyone.
I'm still a pretty princess.
You are, Roman.
Still a pretty princess.
Good times. And now we wait.
And now we wait for everybody to join. And we're going to talk about, yeah, we have one person.
Hello. Bones points to the one person who showed up early.
Yeah.
Ooh. You want to go on time?
Is there a waiting room for this, Megan? Like, are people kind of waiting for the show to begin? Or does it you have to hit start at 4:30 on the dot? How's it work?
No, so this is the Facebook Live event. So it's going to be on there on our Facebook page, and then it just kind of pops up as like a video that's going on right now. And since it's live, they can just kind of click in it and comment and just kind of talk with us if they want. And then when it's all done and recorded, then they can watch it. But do you guys want to start off?
Sure, absolutely.
Yeah, let's go.
So thank you, everyone. Happy Thursday. Yeah, Thursday.
Yeah, it's Thursday.
Happy Thursday, everybody. I hope you're all safe. My name is Dr. Roman Zhang. Joining me today is the wonderful Megan, the legendary Megan, and my good friend, David. David, do you care to introduce yourself? Tell everyone what you do, how awesome you are.
For sure. For one, I don't think I'm too terribly that awesome. First thing, I'm extraordinarily humble, as you can probably already tell. I'm an MD4 from SGA Anguilla. I'm our SGA student body president. Nothing too terribly much besides that. I kind of keep myself away and study most of the time. That's all I really do. I crypto mine. That's about it. The one thing I can do without actually having to leave a textbook.
I heard it had a major crash the past couple of days, right? Past 24 hours?
Down from, I suppose not the past couple hours, but it's down from 35 to, what are we currently sitting at? I may or may not have these statistics pulled up directly next to me. It's at like 31, 32, fluctuating around there. It was at 40 a few weeks ago at this point.
Cool.
So it's not crashing, it's like, but we're off topic.
Okay, off topic. So once again, thank you everyone for joining in today. Like all our webinars, it's very interactive. Please communicate with us. We get distracted easily, so if you have questions, you have comments, suggestions, please add them to the comment box. Megan can filter them as she sees fit, and here we go. Share my screen really quick. All right. So went through all here. Today we have a 33-year-old male coming to the clinic with complaints of pain with swelling of his left big toe for the past day. Did not see the previous episode. Yes.
Do you want to make your screen a little bigger? Sure.
Oh, I'm sorry. That's right. That's right.
Yeah. Fired up in presentation. There we go.
My mistake.
There it is.
So where was that? We have a 33-year-old male who has pain on his left big toe, recently diagnosed with nephrogenic diabetes insipidus. Patient exercises way more than I do, follows a vegetarian diet. His vitals are as follows. Temperature of 98 degrees, BP of 115/73, respiratory rate of 14 breaths per minute. Upon physical exam, you notice left big toe erythema and tenderness of the first metatarsal-phalangeal joint on his right foot. Upon lab analysis, you, the physician, suspect that the treatment for nephrogenic DI is the cause for his patient's acute gout attack. So which of the following medications caused this patient's presentation? Desmopressin, conivaptan, hydrochlorothiazide, allopurinol, or demeclocycline? So here's an image of the toe. As you can see here, low erythema, low swelling, the metatarsal-phalangeal joint. Mr. David, do you care to go over this picture right here?
For sure. I've been staring at things like this for far too long in both my personal and professional careers at this point. So the first thing that I notice when I look at this is the negative bifringent crystals in this sample, which immediately tells me, okay, this is not due to biomechanical stress.
Perfect. So let us continue. And Victor, take it away.
For sure. So this is a little background on diabetes insipidus, and please let me know if I'm talking too fast. I know I have a tendency to kind of pick up speed. Yeah, feel free to cut in whenever. So diabetes insipidus is a leading cause of euvolemic hypernatremia. It can present with severe polyuria and mild hyponatremia as well. It's usually in two types, etiology or urosmolality. It could be central or nephrogenic. So just a quick and dirty way to explain that. Central DI, you're actually losing production of the hormone that tells your body, hey, we need to keep some water in. So it thinks, okay, we just don't need to keep any water in, and you start hemorrhaging water through the urinary system, right? Nephrogenic DI, your kidneys can't tell that it's secreting this signal. So it thinks, okay, we don't need any water, out it goes. And that's that. Another few common causes of any of this could be hypercalcemia, severe hypokalemia, tumor interstitial renal disease, and a few medications like lithium, foscarnet, cidofovir, and amphotericin. So your antifungals and your antivirals. Roland, flip up the next one.
And like David mentioned, I think the two major things right here, in central DI, you have a decreased production of ADH production. In nephrogenic DI, the ADH is, the kidneys are resistant to ADH. So this will be a major concept that will be really critical later on. Okay, sir.
All right, here we just got like a handy little visual, so you can see, you know, you've got your posterior pituitary here, you have your adrenal, you got your kidney, you've got the whole shebang. And you can see if you have decreased ADH, you're going to have high serum osmolality, right, and low urine osmolality. And ADH given will correct the problem. But if you have a receptor defect or damaged receptors, as in peripheral diabetes insipidus, then ADH isn't going to help the problem whatsoever.
Good. So let's take a look at this vignette one more time from the top, right? So we have a 33-year-old male coming to your clinic with symptoms of gout for the past day. He has previous episodes. Actually giving the diagnosis, he has nephrogenic diabetes insipidus. The next part is that the fact that he exercises 5 times a week, follows a vegetarian diet, he's a healthy male, healthy 33-year-old male who happens to present with gout-like symptoms. So what caused his nephrogenic DI? So we're asking a pharmacology question, saying which medication caused the pathology, and if you need to know the physiology in the biochem to cause this syndrome. So for everyone watching along, what do you guys think?
Just to note, this is really more of an integrative question than it leads on to be, right? Like, sure, you can know the pathology, you can know the physiology, but unless you know how these things interact, right, it can be a little tricky to know exactly where this question is trying to lead you.
Yeah, so on social, when we posted this question last week, a lot of people were saying that it was C. So how does that look for the answer?
Okay. Mr. Davis, shall we continue?
We shall. Let's let them know.
Let's let them know. Hi, sir. Floor is yours.
All right. So cutting straight to the chase, the correct answer is indeed C, and we'll explain all of these answer options in a little bit more detail so you get both the right and the wrong. Just starting with A at desmopressin. So it's used to treat central DI, hemophilia, and von Willebrand's disease. It would not have caused the high uric acid levels seen in this patient, high uric acid levels leading to gout, and it would have caused a low serum plasma osmolality. Conivaptan is an ADH antagonist used to treat severe hyponatremia. Sorry, I'm stumbling on my own words here. It would have caused hyperosmolarity, but wouldn't have caused hyperuricemia leading to gout. Allopurinol, ironically, is a drug used to treat gout, so you wouldn't have seen gout in this patient. It's used for acute attacks, or not acute attacks, it's used for prophylaxis and not acute attacks. That's an important note. For acute attacks, you're better off using something of like colchicine or something like that, an actual inhibitor. There's a few adverse effects like Stevens-Johnson syndromes and acute gouty flare if you use allopurinol, but it is useful in kidney stones and gout prophylaxis. Democlocycline is tetracycline, so an antibiotic, but it also can aid in SIADH, but the counterpart can cause diabetes insipidus. And the correct answer is C, hydrochlorothiazide. It causes hyperuricemia, hypercalcemia, hypoglucemia, hyperlipidemia. The only thing that it doesn't cause hyper, basically, is kalemia and natremia. And then can anyone tell me the difference between osmolar findings in central versus peripheral DI and how to diagnose? I'll let that sit for the chat for a quick second.
And while everyone's thinking about that, I just want to point out the fact that, like David mentioned, it's not used, the allopurinol is not used for acute attacks. One thing you want to keep in mind is that pain is a huge factor during acute gout attacks. So you always want to manage the pain first and foremost. So like an NSAID, Tylenol, whatever kind of pain medication the patient could tolerate based upon that. One tricky aspect is that if the patient has any kind of kidney issues, you gotta make sure that whatever medication you're treating for pain is not nephrotoxic. So pain medication is not nephrotoxic, right? All right, Ms. Megan, what do people say about Dave's question here?
Looks like we've got a couple responses rolling, but we're gonna let it sit for a minute to give people a few more seconds of thought.
And I apologize, I just saw that you have NSAIDs right here. My mistake, David. Well done.
Processing always takes a little bit of time after all. Well, while we're thinking about that, let's flip to our next slide. We'll flip back to this one. So this is a nice little physio slide that I dug up from the vast wealth of information that is Google image searches. That kind of shows the physiopharmacology of how hydrochlorothiazide actually causes hyperuricemia. So the names of these ion channels, their full names, I couldn't tell you. I feel like most people couldn't. Most people aren't going to ask you the full names of these ion channels, but the abbreviations are good to know. So you've got SLC5AB here. That's your, or 588. I always do that. That's your standard sodium anion channel. It's a symporter, and then you've got your URAT1. That's the one you kind of want to keep an eye on because that's the one that actually flows out anions, which counts as hydrochlorothiazide, and flows in uric acid. And that's probably enough time letting that stew. So if you guys want to take a picture of the slide, we'll hold it up here for a few more seconds. And then we'll hop back to the previous slide. And the osmolar findings between central and peripheral DI and how to diagnose. Let's see, do we have anything? All right, so looking straight at this, right? So if it's central DI, you're gonna have low ADH, and your body is just going to be losing all of its water, right? So this picture entirely is how you answer this question. So looking at it, if you have no ADH or low ADH due to tumor or hemorrhage or whatever have you, then you're going to have high serum osmolality and low urine osmolality, and correct it after ADH is given. On the counter side of it, if you have peripheral DI, you're going to have a receptor defect or receptor damage, or some form of blocking that. It could be due to dimethylcycline. You're going to have high serum osmolality and low urine osmolality, and ADH will not correct the problem.
Correct. So that is basically today's webinar in a nutshell. We would like to kind of give the floor to you, our wonderful viewers, as in, what do you think about this question? Was it difficult? So on a scale of 0, no problem, really easy, to 10, I have no idea what you're talking about. How difficult was this question? How relevant was this question for those of you who are studying for the MBMEs, your MD 1 through 4 exams? How relevant was this question to your studies? Same thing for the answers. How relevant was the answer? Was it something that you were familiar with? Did you know what we were talking about? Were you familiar with all the pharmacology, all the names, the nomenclature? The last thing I think I want to go over here is tidbits to learn. So let's look at this question again, right? So for those of you who are studying, do you know what nephrogenic diabetes insipidus mean? I know all of you are familiar with diabetes mellitus, and the hyperglycemia, the A1Cs, the patient who has a blood sugar of a Snickers bar. But do you know what diabetes insipidus means? At the same time, if you look at this word, do you know what I'm talking about? Do you know what this what these medications are? Do you know what they do? Do you know how they interact? Do you know the side effects of them? So even though we only presented one question, there are, what do you think, David, 10, 15, 20 things that they can look up on their own? Like, when would you want to use these medications? Right? When do you not want to use these medications? So that's why I really wanted to include this slide right here, tidbits to learn. Each vignette, each question has so much to teach you if you take the time to really dissect it or break it apart. If you want today's PowerPoint as for your own studies, please email us here. If you want any more information, for those of you who are interested in joining St. James, want more information, please feel free to email us here. And that is it from us. Ms. Megan, anything else?
No, just thank you all for tuning in to join our Facebook Live session so we can review last week's USMLE prep question. We'll be back every other Thursday, so not the next coming Thursday. We'll be posting a normal question on all of our social media accounts, and then we'll be coming back that following Thursday to kind of go over the questions like we did today with another amazing guest speaker. And Roland.
Okay, and Roland. Before I say goodbye to everyone, to my one student who said the answer choice was too easy, good job. I know you're studying hard. And to all of you watching, thank you so much for having us. A huge shout out, huge thank you to David for joining us today.
A pleasure to meet you.
Taking time out of his busy schedule. The wonderful Megan, thank you for having me specifically. Definitely inflates the ego quite a bit.
Of course, thank you so much for being with us.
For all of our wonderful viewers, please stay safe. Have a great Thursday, and we'll see you all next time.
Bye, everyone.